Thank you. Welcome today to the Family Support Services Statewide Committee Quarterly Meeting. My name is Ted Kasser. I'm the Commissioner for OPWDD, and let's begin by introducing the individuals who are attending today's meeting in person. Yep.
Good morning, everyone. I'm Tamika Black. I'm the Deputy Commissioner and Chief Data Officer of the Division of Data Management and Strategy in OPWDD.
Good morning. I'm Jackie Best. I'm the Regional Office Statewide Operations Director.
Sally Berry with Regional Offices.
Maria Suchi-Kozak, Council Member.
Deborah Gray, Council Member, Brooklyn.
Margaret Raymond, Council Member, Central East.
Alia Hussain, Council Member, Queens.
Gail Pato, Council Member, Broome Region.
Margaret Puddington, Manhattan.
Mary Fasano, Long Island.
Ian Sheriff, Council Member, Western North.
Almirada, Taconic, DDRO.
I'm Josie from the Commissioner's Office.
And then there are members who are participating by phone, if they can introduce themselves. Okay, I think that's it. That was incredibly orderly. No one interrupted anyone on the phone, which is amazing.
We talked about it before you got here.
Yes, we're all good today. We're practicing.
We're going to begin with the presentation by Tamika Black, who's going to talk about using data to support quality outcomes for people.
Thank you, Commissioner. Can everybody hear me? I'm still fighting a little bit of a cold. I want to make sure. Can you hear me? Okay. Doesn't seem to be advancing. Just hold for technical difficulties. Okay, thank you. As the Commissioner said, we're really looking at using data to support quality outcomes for people. And today's agenda, we're going to review the OPWDD data strategy. We're going to outline the IDD Health Home Program and really talk about Lifeplan development and quality and performance measurement, and then provide an overview of the Lifeplan data system, including goals and data flow. There's been a lot of interest lately in the Lifeplan, how data will be extracted from the Lifeplan to develop quality measures for CCOs, and I'm looking forward to today's discussion. We started in OPWDD when I took over the Division of Data Management and Strategy at looking at the OPWDD data strategy and what we wanted to accomplish. We really wanted to focus on promoting accountability and transparency for individuals, families, providers, employees, and all of our stakeholders. We also wanted to provide accurate and timely and actionable data to support effective decision making. We also wanted to make sure that the IT systems we were using had integrity as a data source. We also wanted to balance quality and performance reporting with assurances that person-specific confidential data is handled appropriately. Our data strategy has 5 major components, and the first one is the development of a data roadmap, which began in early part of 2019, and it outlines high-level milestones for achieving our strategy. The other part is data governance, and that's ensuring accurate and reliable sources of data and safeguarding data for privacy and security controls. We also have a focus on data sharing. Who gets the data? When do they get the data? How's it shared? And part of that is developing data use agreements to share data. We also have a quality strategy, and that is about monitoring service and delivery and monitoring service delivery and provider performance. We also convened a clinical advisory group in 2019, and we also are exploring the development of new quality measures, which we'll discuss today. In addition, we have a component related to open data and creating public-facing displays of aggregate data, which we hope to launch in the spring. The data roadmap, which is the first component of the data strategy, has 5 key areas. As I mentioned before, we really are focusing on data governance and creating a systematic approach to managing data and disseminating data. We want to focus on innovation, especially internal to OPWDD, looking at data access and use and how data is shared so we can become more transparent with our stakeholders, making sure we leverage our IT infrastructure, both our legacy systems or our current systems, as well as new technology, and then again, that we're ensuring security and privacy. This strategy is important because it underlies the things that we're looking at in terms of measuring performance for our OPWDD DOH initiatives. The first part of that, as I mentioned, is our clinical advisory group, and they're focused on evaluating measures and deciding what measures are really important for looking at quality. The second piece is how we're going to enhance the performance of health homes and how we're going to use Lifeplan data to do that. I'm starting off with the clinical advisory group and just mentioning a little bit about how that evolution has occurred. The first clinical advisory group was convened in 2016, and the current CAG is building on that work of the previous clinical advisory group. The goal of the group is to consider and review key considerations related to quality measurement related to value-based payment. We're also going to make recommendations and provide feedback for quality measures for IDD populations. The CAG is comprised of members that have clinical expertise and industry knowledge. We took members from across the state so that there was geographic diversity, and we wanted expertise areas that represented the total care spectrum experience for IDD population. We asked that the CAG attend quarterly meetings and actively participate, and our recommendations will be disseminated to the Joint Advisory Council for their review before the recommendations are submitted to the Department of Health. The Department of Health also participates as part of the CAG, and the CAG is co-chaired by members from OPWDD as well as DOH. The CAG has a 2-year commitment, and they are the ultimate authority when we think about selecting measures for OPWDD with stakeholder involvement. The CAG has done substantial work in 2019. In 2020, we're going to be really focusing on measure selection. We've done a lot of level setting in 2019, backgrounds, really understanding what VBP is, how we could potentially apply it to IDD. Now we're moving forward with actual measures. In the first meeting for Q1, we hope to finalize how we're going to evaluate those measures. What are the criteria we're going to use? And what are the chronic conditions or health problems, factors that we're interested in looking at, and then identifying potential measures. In the Q2 meeting, we really want to look at the covered services and benefits as we think about our transition to managed care. How will we think about that benefit design and how we'll move forward? We're also going to be analyzing existing measure sets using that evaluation criteria. In Q3, we want to make sure that our measures are feasible, and we want to prioritize them based on what we can actually collect and analyze. We also want to look at what other states are doing and then consider any other operational issues. And then finally, in the Q4, we're going to review the completed work and submit our recommendations to the JAC, and also think about the scope of work that we're anticipating for 2021. In terms of the IDD Health Home Program, the focus is really on person-centered planning to develop life plans and identify goals and outcomes that are important to the individuals we serve. In collaboration with the Department of Health, we're focused on care managers providing enhanced care coordination and doing that in a conflict-free case management model. There are 6 core services for any health home, including the IDD Health Home, and that is comprehensive transitional care, comprehensive care management, care coordination and health promotion, referrals to community services, individual and family support, and health information technology to link services. And we'll talk a little bit more about the HIT pieces as we move forward. I'm sorry, I skipped. So in terms of the life plan, as we know, it's a comprehensive assessment that really focuses on the person's life and what's important to them and the outcomes they'd like to achieve. It is a collaborative and reoccurring process-driven approach and driven by the person. It describes who the person is, again, what they want to accomplish, and their goals and valued outcomes. It should integrate all services and natural supports. It should be understandable to the person, and it must be agreed to and signed by the person and their interdisciplinary care team. When we think about health home performance and the key areas that we're anticipating gleaning performance indicators from, the first part is technical assistance. OPWDD and DOH are conducting technical assistance and designation reviews to ensure health homes are providing quality care. The other component, which the Division of Data Management and Strategy is actively involved in, is the Lifeplan data system. And that's where CCOs share key data elements from the finalized life plans with OPWDD so that we can monitor life plan quality and calculate IDD-specific health home measures. The third piece is the development of IDD health home dashboards in which OPWDD monitors the performance of CCO health homes on key performance metrics. So those are the three key areas. We're currently in the process of that technical assistance and designation review process. The life plan we're beginning, and we'll talk a little bit more in the remainder of the presentation, and then ultimately leading to the development of the dashboards. So OPWDD is really focused on assessing CCO performance, and this is how we plan to collect and use the care plan data. We want to calculate the CCO performance measures. We want to ensure that the risks identified in the assessment tools, such as the CAS, which is the Coordinated Assessment System, are addressed in the care planning process. We want to better monitor preventative health care. We want to analyze aspects of care not identified in enrollment and payment data. We want to improve linkages of OPWDD services to specific outcomes, and we want to support emergency management. As I mentioned before, we were going to delve a little bit more into the health information technology side of things. There are three major components of our health information technology framework. The first is the care management system, also known as Metasched. The next one is the care coordination data definitions, which is known as the CCDD, and then the life plan data system. So I'll explain how these components work. The care management system is used by the CCOs to help track and deliver care management services, and it documents and creates the electronic life plan. It also meets the requirements, the minimum data set needed for health home services, which is contained in the care coordination data definitions. So if an IAM is completed, it helps, the IAM is a tool, it's a questionnaire and tool used to help develop the life plan. The information from the life plan is entered into the care management system, known as Metasched. The care coordination data definitions are the minimum amount of data out of the Metasched system, which are the fields that OPWDD has specified are important and the types of data those fields should contain. That data extract is transmitted using the CCDD into the life plan data system. So the CCDD is the minimum data set. It ensures that care systems are using the same standards. The CCDD is not specific to Metasched. It is a set of definitions that, irrespective of what vendor is used, it's the form and format data needs to be transmitted to OPWDD for the purposes of quality. So it's almost like any electronic health record or care coordination, care management system has to be able to transmit data to OPWDD in this format as specified by the care coordination data definitions. And again, that data is then transmitted into our life plan data system. That is where OPWDD extracts information about quality measures. It stores data received from the CCOs. It supports the reporting of health home measures. That's what will be used for research and analysis, and it supports oversight and compliance for care planning. So those are the three major things that I think we want to reinforce at this point. So this is a flow of how it works, and I just explained it, but I'll say it again. We start with the person-centered planning process with the CCOs. That information gets put into the life plan. The life plan information is entered into the Metasched care management system or any care management system that's chosen. It's then transmitted through a CCD data extract or definitions extract to the Lifeplan data system, which is at OPWDD. OPWDD then extracts the data, uses it to calculate measures, and those measures will then be incorporated and displayed through an OPWDD dashboard. As I mentioned before, the CCDD establishes data standards between OPWDD and the CCOs. The definitions allow care coordination providers to share Lifeplan data in a standardized way and format. If anyone is interested, they can actually look at the CCDD on the OPWDD website. It's about a 102-page document, and you can find out. But we're actually going to talk a high-level overview of what's in the CCDD. This is probably a little bit hard to read, but the CCDD has 11 sections in it. I'm going to provide a quick high-level overview. The first section is demographic and profile information. So essentially, you're going to get the individual's name, address, ID numbers, billing information, CCO information, like who's the care management team. That's provided in Section 1. In Section 2, which are outcomes and support strategies, it identifies the valued outcomes and action steps to achieve those valued outcomes and who are the responsible parties for achieving those outcomes. Section 3 is the health and safety section, also known as the IPOP section, and that has information on safeguards and supports and for the safety and health of individuals in community settings. Section 4 is authorized services, which focuses on authorized HCBS waiver services, including provider names, identifiers, duration, units, frequency, and self-direction. Section 5 focuses on natural supports and other services and community resources. Section 5 has a lot of text-free descriptions of individuals' natural supports, the frequently used community resources, and healthcare provider info. When we think about the life plan, there's typically two types of information, one that will have drop-downs and the others that have text narrative. To the extent where information cannot be tailored in a drop-down, we'd expect the text narrative to contain some of the individualized information about the individuals and their desires and their needs for services. 6 is the preventive medical planning, which focuses on dates of recent exams, tests, prescribed medications, and the last or most recent hospitalization. 7 has behavioral support needs, included psychiatric conditions and behavioral supports. 8 focuses on employment and information on paid and competitive employment. 9 is personal outcome measures in a section for future use. This is supposed to be under a managed care environment where there's a sample of, the state will issue a sample of providers will conduct CQL interviews and then provide us with the outcomes of those CQL interviews to determine whether outcomes are being met. The Willowbrook supplement is for class members only, and that has information on representation status, community inclusion, and hospital staffing coverage. And then 11 is risk factors, and that's a temporary section. It will be replaced eventually by the CAS when CAS implementation is complete, but it has the risk of falls, choking, aspiration, and desire to pursue employment, among other things. So that's the life plan. The next section we're going to talk about is the quality measure process. And we've discussed this before when I did a presentation with the DDAC and the Joint Advisory Council, and that is quality measurement is an iterative process. And that measurement design often occurs without the benefit of data when the new program is being implemented. And that was the case with CCO implementation. Measures had to be identified before we had any experience with the CCOs because those measures were contained in the application. What's going to happen is as we begin data exchange and get familiarity with the data and do analysis and data mining, we will refine those measures and those measure specifications. And I think that's something I want to just have everybody understand, that it's an evolving process. There's an evolution to measurement, and that we will continue to look at measures, whether the measures are effective, whether they're really measuring what we think they are there new measures we want to propose. So measurement is always moving forward. In terms of measure specification, there's a lot of things about a measure. It's not simply, choking. You really have to identify the measure name, the description, the intended use, the types of data elements, what codes and value sets, what are the numerators and denominators, and we'll show an example of that. the data collection, how that data will be collected, how it will be stored, what's the method going to be used. And then there are other factors about whether it's baseline, improvement over time, and other factors. The other thing about measures that we have to be cognizant of is that there are things for evaluating whether a measure is a good one or appropriate. We want to look at the relevance of the measure, whether it's useful for quality reporting and decision making, whether it's at the right unit or level of analysis, sort of is it about the individual, are we measuring provider, are we measuring the system? Is it a valid measure? Is it free from any kind of bias to it or errors? Can we actually make good conclusions based on it? Is it accurate? Is it reliable? And what is it? Is it really appropriately well defined? Can everybody understand it? Is it implemented consistently? You know, if one person's reporting one way and someone's reporting another way, it's not going to be very reliable. And can it distinguish differences in performance? And then lastly, is it feasible? We've had a lot of challenges with getting data. Do providers have it? Do entities have it? Required data really has to be available and captured without undue burden, and it has to be able to be implemented for a performance measurement purpose. For anyone who is interested, the Health Home CCO quality performance measures are actually available in the application. And the performance specifications are also available on the DOH website. So you can actually see the health home specifications there. And hopefully this slide is readable. This is actually an example of the measures that are in the CCO application and then DOH health home measurement specifications. I'll give you an example of the first one. The measurement is implementation of CQL POMs. The numerator is actually the number of people with IDD who have a life plan with a minimum of 2 POM measures. The denominator is the total number of IDD health home members with life plans. So there's a way of specifying measures so that you can actually have a number and a score to be able to calculate. There's also a new measure from CMS, and that is the measure for institutional admissions. And that's the number of admissions to an institution among health home enrollees age 18 and older residing in the community for at least 1 month. I mentioned in previous meetings that the specification for this measure is 6 pages long. That's the kind of detail it goes into so that everybody can report in the same exact way and that measure becomes reliable and valid.
Susan, if you can please mute your phones on the conference call, that would be great. Thank you.
So some of the work that we've done already in 2019 is that we work with NICEC, who's a consulting group, to really crosswalk the work we've been doing with the care coordination data definitions with national standards. So there are national standards for actually data collection and for care coordination. And then there's been an ongoing review and update of these requirements. And they've also been working with Metasched and the CCOs to make sure that the coordination, the care coordinate and IM systems are addressing challenges. Are there any gaps? Looking at gap analysis. In September and October of this year, we actually tested to ensure there was a secure connection between the CCOs and OPWDD. We actually looked at the mapping. The CCOs reviewed that. The mapping of the Metasched system to the CCDD to make sure we were capturing appropriate fields and data elements. And then the testing of the connection was completed in December. In late December, we were going to respond to the CCO request for clarification. The CCOs wrote OPWDD about fields and certain things that they wanted to resolve. We've been having a series of work groups and meetings to be able to do that.
All right, so I'm just going to remind the members of the committee who are on the phone and calling in if they can please mute their phones so that we don't get extraneous noise from your homes. I would appreciate that very much. Thank you.
Thank you. We also hope to transmit full life plans in terms of test data in January, transmit actual records for CCO enrollees in March, and then create the reports and do the validation process in order to get to measurement development between April and December 2020. I know I've gone through a lot of information. Some of it's very technical, but I wanted to give everybody a sense of how that person-centered planning process sort of segues through actually getting to performance dashboards and to quality measures. So at this point, I don't know if anybody has any questions, concerns, issues.
This is very technical and very lengthy. Can we get you a microphone? This is very technical and very lengthy. This is, hello?
Now you're good.
Okay. It's very technical, very lengthy. Is there any way that we can get a summary of all that you said? So that we can present this to our councils, our local councils?
Sure. So let me just kind of summarize what you just heard. You may have heard me speak in some public settings, and I may have said it here, that when I arrived in January, one of the things that we lacked was an ability to access data from our care coordination system, right? And in fact, when we wanted to understand the performance of our system, we actually had to send out a request to them to send us data either on paper or Excel spreadsheets. But we had no means of connecting to our CCOs electronically, of pulling data out of their system, or providing an analysis of that data. So I think what Tamika has done is to provided the group with a sense of what we are doing to build an IT platform that will provide us with data from CCOs that we can then subject to analysis in order to understand the performance of our care management system. And it was really technical. And I think it's important to understand the technical nature of it so that we're not naive or simplistic in what we can expect from our system and the data and analysis that we can perform. So, for example, February, I would run into Tamika's office and say, Tamika, we have all this data in the CCOs in Metasced. I want to do this. And she would look at me and scratch her head and patiently kind of walk me through this and say, I understand what you want. I agree that it's important. But you, Commissioner, need to understand that this is what is required to answer your question. Even to the level of it takes 6 pages to define an item and how that data should then be collected. So it was really technical. It was very in the weeds. But I think as members of this committee, it's important to know that so that when you say to us, we want to know how things work, the answer may require us to address each and every one of the steps that Tamika just outlined. So for care coordination and CCOs, we have a lot of work to do to get from where we were in January, really completely blind, to where we want to be, which is to be able to interact electronically with our 7 CCOs, be able to pull data for 107,000 individuals and look at the performance of our system, at scale, the entire state, all of the data, all of the metrics that we think are important. But identifying those metrics, creating them, aggregating them, analyzing them is a really, really complicated process. Does that work for you, or does that respond to the question? Okay.
Yeah. Commissioner, thank you. I appreciate you distilling it down to really how do we know the system is performing? OPWDD is building IT systems to support the exchange of data to know how the system is performing. We're using Lifeplan data to begin looking at that.
In my own words, if I can reframe back or phrase back, it's establishing a baseline where we're at now. And as you're going forward, the more information you get, that's going to that baseline or whatever, the path might change a little bit depending on the information you're gathering. Is that correct?
That's also true. Yes, it is.
So just as an example, when we first started the discussion about CCO evaluation, The question was, what percent of individuals have completed life plans? Back in January and February, it was about 5%. We had to ask the providers, the CCOs themselves, to tell us what percent of individuals had completed life plans. With a system such as this, we would be able to go into the data set and pull that information and do it ourselves. As we move to more qualitative things about the CCO operations, not just, does an individual have a life plan, but do they have a care coordinator? How frequently do they meet? Are they satisfied with the care coordinator? Those are subsequent questions that we hope to be able to answer, but we would need a system like this to be able to do that, rather than saying, okay, here's a survey, you tell us. So this is a process that evolves over time and allows us to target things we want to look at, things that are important.
I think we found out through Family Support Services years ago, looking at started using tabs to identify people that were getting services, where before relying on feedback of we serve 10 people, but who are those 10 people? And then once you started using tabs, you could pull it out and figure out who those 10 people were. So
I'm constantly amazed at how complicated the IT system is that surrounds OPWDD. There is tabs, obviously. There's abuse and neglect data in one set called IRMA. There's CCO data in Metasched. There's an electronic health record that's being built out. It's really a very complex system that's built upon functions that weren't necessarily designed for OPWDD, but that exist and we have to use. So this is just one little look at one little part of it, but the whole data infrastructure is really complicated, and our ability to blend data and pull things from different places is not what you might expect for an organization of the size and scale that we are. We're an $8 billion business, if you will, and we lack some of the very basic management tools that large organizations typically have. So we're building that. Tamika is doing a great job. Her team is incredibly responsive, forward-looking. They're pulling all of us within OPWDD along, and it's a lot of work, but they're doing a really excellent job at it. So it's been very helpful.
Would it be possible for us to have a copy of the PowerPoint? It would help us to digest some of this material.
Yes, it's my understanding that Josie will be disseminating it to all the committee members.
Okay. Also, I would like to raise an issue that we discussed at the Developmental Disabilities Advisory Council last week, and that is the life plan, and what kinds of information it could yield, given what some of us see as certain flaws in it. For example, there are drop-down menus throughout the life plan that limit your choices. And so, for example, I wasn't able to specify the full extent of my son's disability because the drop-down didn't permit it. There was no way to say that he's nonverbal. There was no way to say that he has fine motor limitations and gross motor difficulties as well. All we could get it to say was he has intellectual disabilities, which is true, but that doesn't begin to present a picture of who he really is. In terms of his desired outcomes, the choices were really very limited. It was whether you wanted to volunteer, whether you wanted to be more independent, and maybe there was another thing. But if you only have those limited options, the data that you're going to get from that is not going to be very meaningful. For example, my son doesn't want to volunteer. He would like to be more independent, though. But that's, we need more choice in there. Also, the drop-downs for medications was very, very sparse. So we could only list like maybe 2 of his medications when he has like 10. I forget what, where you could specify what his goals were. There was really it seems to me that would be the heart of it, that you would want to say, what is it he wants to improve on? What is it he wants to work on? And specifically, not just I want to be more independent, but in his case, I want to communicate better. I want people to be able to understand me better. there was no way to get that in there, and that to me is really the crucial piece. So there was a lot of discussion at the meeting last week about this, and we wanted to kind of raise it again and see what other people think. And so, does anybody else?
Yeah. Margaret, I agree with you 100% because, you know, not even my son is is high functioning. He doesn't want to work. And there's reasons. My son is on a ton of medications, and all of them are very important to have to be listed because he's gotten old and certain illnesses, diseases he's acquired. And it does happen to individuals who have developmental disability, they get it earlier. And he's also on specific diets because food allergies. And a lot of times it's the hardest thing to get them to understand. This is very important because even though he may be able to communicate, but if he starts going to anaphylactic shock and he's not near me, nobody else, how are they going to understand what's happening to him? My other concern is the OPWDD, I'm glad the tech system is being rebuilt because a lot of times we can't, when we try to get into your system to talk to your system, I'm talking about the emails and internet, it's very hard because it's like you're on Windows 7 and we're like on Windows 10 or above. So I'm hoping that you're also, because that's very important for the data to be able to seamlessly go between the CCOs and also families. Also, I hope that quarterly we get the reports too of how the improvements that you've already worked on are going, or how are they going? Have we progressed or are we going backwards? We need to know are we going forwards or backwards? And I also hope you spread out when you do the life plans, because not every, when you say someone wants to be more independent, what kind of independence? Everyone says, I want to be more independent. But do they understand what kind of independence they want or need? And it's never really discussed. So we need that because that's a true life plan. So I hope that can be done.
So just going back to your comment, and I'll reiterate what I said earlier. OPWDD had very little participation in the process of selecting an IT vendor, creating the IT system that supports the 7 CCOs. There was a decision made at the launch of the CCOs that function would be delegated, distributed, that each CCO would engage an IT vendor to provide IT support, and then each CCO worked with that vendor to customize the process of building the IT platform. So we made a decision 3 years ago that we were not going to centralize or standardize that. We've revisited that as I think this is clear, that we need to have more control over the manner in which the questions are asked, the data is collected, aggregated, and analyzed. We're fortunate that the 7 CCOs all chose Metasched for some unknown reason, but that allows us to now go to Metasched and coordinate with a single entity who's actually providing IT support to those 7 CCOs. This process is looking at what we can accomplish within the current IT structure that's been established by CCOs and Metasched, adding additional questions, as I think Tamika suggested, is not simple. It requires a process of discussing, for example, what the word independence means, creating the specific data, the form, the process inside the CCO, how the data gets entered, where it gets entered, and then working backwards up into OPWDD. So changing what's currently in place is going to be a big lift. Now, what we're trying to do is to move from, the simple benchmark of does everyone have a life plan to whether, to the question of is that life plan any good? And I'm sorry that Allison isn't here, but she's been working with her team and the CCOs. They're meeting on a weekly basis to talk about more qualitative items within the life plan, things like accessing your care coordinator, whether the life plan actually reflects the outcomes that people want, and trying to measure those and then create a report that can be shared with the public on the CCO's capacity to meet those more subjective or qualitative metrics. So we've already talked about putting the completion rate for life plans online with the 7 CCOs so that our individuals and families can see how CCOs are performing. We've also talked about creating a report card-like system that can be put online that families and individuals can see, and they can look at the performance of their CCO along those more qualitative or subjective measures. And we're looking at something that's like a 3-color code. Green is good, yellow is like in the middle.
Why don't you use what the Department of Health uses for restaurants? A, B, C, D, and if you go below that, you're not opened anymore.
You could use what CMS does for nursing homes. You could use 5 stars. There's tons of ways of presenting data, but we think something along those lines that kind of says this is good, this is in the middle, and this is not good would be helpful to our community in understanding CCO performance. So we're trying to get to some of the quality metrics that people are really more interested in. We're probably not going to get to yours, Deborah, because that's going to take more time. But
I'm
at least
aware of that.
moving it along.
I'm aware of that.
I know.
I mean, I'm totally aware because, the IT person happens to be not far from our office, and he tells us regularly. And like when we have issues, when we're at the DDRO with, going in and out of the end, he's come in to assist us. But he said to me, the system is slowly being built. We understand that. I'm not rushing because I'd rather you do it right than it be broken.
It's going to be better. It's not going to be perfect.
I understand that. You're going forward. That's what I like seeing. And by the way, I just want to bring up an update. I had a joint meeting with my DD council in reference to CCOs for the medical form that I brought up. Was really insistent they have their name on. ACA and Tri-County definitely already have a medical forms with it's from Tri-County or ACA. Care Design agreed to do that. So we were very happy in Brooklyn because our families said, my kid's involved in so many different things. I can't, I can't have a blank form. I have to have it from your group because they write it down for what's needed. So that it was corrected, we're happy. So we wanted to give you the update.
All right, thank you.
Welcome.
I just wanted to say something good about Lifeplan because with my care coordinator, we had like 1 semi-annual, 4 addendums, just because the FI takes her own sweet time to review and send us a request for change. So basically what I am trying to say here is the teamwork. If the information is properly delivered to the care manager, of course that will be put on to the life plan. Now, there are a lot of drop boxes, but there are some, like Mr. Mika last time mentioned, the life plan is divided into 11 sections, if I'm not mistaken. So one of them is my work, where we can in a small few sentences describe what the work is. And then the relationship comes in, my health, where there is a full description that if you close the life plan, read the life plan, you can portray Zobi, my son. The life plan is so good. But still, when we get the request that, no, this is something wrong, the care manager corrects it. So there may be situations where the care manager is a new person, maybe it's a new job for her, she's still getting in touch with the system, the IT, because everyone is not computer savvy. We have to say that as well. But the life plan basically is the most important, like a milestone for a child to get all the services, which moves forward to the Section 2 and Section 3, which I have my life plan right here, and it describes so well what are the goals, all the goals will not be achieved, of course, but this is what the boys want to do. and then that moves forward to how it's going to be accomplished. Through who? Through the FI, or through the staff, or through the natural support. So I must say that every section is very important. Description is important, but the goals as well is important, and moving forward is like how it's going to be handled and delivered, both ways. The teamwork is between the provider and the family member, also the individual. That's what I think.
All right, thank you. Yes.
Oh,
Yeah,
okay. I was just kind of thinking, it kind of goes back to the education and training of the care managers or care coordinators, whatever they're called in the CCOs, because it varies a little, to make sure there's really good training, ongoing training and educational component, because things change, and if they're not kind of kept up to date, it impacts on all of us.
Well, we agree. I think it's been a challenge for many of the CCOs to create a health literate workforce that they have more experience because their backgrounds generally as MSCs in the operations around OPWDD and our service system. But with the Lifeplan, they're expected to be more literate in the area of health. It's not a skill set that they had. There's a lot of variation in that, and that's a big challenge. But I know that the CCOs are working on it. We're encouraging them to work on it.
I'm just curious, are there some models out there that are working with the CCOs that, I mean, I assume they get together and share, but, what's working well?
I'd have to defer to Allison. I know she's not here, but, she's working with all of them to try to bring them up to speed. There are lots and lots of webinars that have been held, and there's a really rigorous training program for the CCO workers, the care coordinators.
Thank you.
Sure, thanks.
Hi, Commissioner. I just wanted to kind of build a little bit on one of the points that Margaret made, but kind of take it in a little bit of a different direction. I certainly, as someone with an education in mathematics and someone that loves to be informed by data, I certainly appreciate what we're trying to accomplish, and I definitely think it's way overdue. And I also understand that change is painful, and that you can't get to the other side without going through that. As both a parent and a provider, I've gotten a lot of feedback from families over the last year and a half, especially the last year. And I'm wondering where in 2020's work, and I'm hoping that it's on the agenda, that we'll be looking at how we can make sure that it is person-centered instead of data-centered, because a lot of families are kind of feeling their needs aren't necessarily being met. A lot of things are being driven by data collection, by paperwork, and kind of going away from the model that they've come to really appreciate, and that OPWDD puts people first. So I just wanted to say that in hopes that that's something that there's some problem solving around, is how can we make sure that in our efforts to collect this data, we're not putting the burden on the care managers who really are there to work with people as well. Also, I just wanted to say about prioritizing goals. Yes, the Life Plan has some absolutely wonderful elements in it. It does automatically spit out, based on previous assessments, what people's goals are, which is fantastic. I think there seems to be some stumbling blocks around how to prioritize those with families, and CCO's drive to make sure that they're capturing all that information, that things are delegated. So I'm hoping that there can also be some discussion and problem solving, and maybe even some solutions built into Metasched, and I know that's not an easy thing, to help identify just a few goals for someone to focus on. And I know it's right now just discussion, but a way to maybe keep a historic record of what someone's preferences and goals are, but move over the ones that they want to act on, so that everybody can kind of be in agreement. We don't need 15 goals just because the IM assessment said you want 15 things. Let's bite size so that we can really make some difference and some progress and document it. So I'm just hoping that some of those things will be discussed in your future work, and thank you for your consideration.
So I think some of the comments but from you and from others are really around CCO operations, and I think that's a topic that is worth spending more time on, having the right staff here.
Sure.
As far as IT, we try to use IT as the means for understanding performance, establishing expectations, building quality improvement programs. Data isn't the primary goal. It's services and support, but the data is really critical to understanding our performance and determining how we move forward. So it does fall to the care coordinators there's no other place that it can fall. They've got to put the data in so that we can access it and use it. It's a distraction. It's unpleasant at times, when a clinician has to divert their attention to, work with a computer, make sure that they're keeping up with their documentation charting. But that's just kind of the way things are when you want to use data. You've got to build the database, aggregate it. So
Right,
it's
but we
a
just
challenge.
want to make sure that it doesn't also impede the whole intent of the service, because if someone's going for a 1-hour plan, meeting to discuss a plan, and 95% of the meeting is capturing data, and then you never get the referrals you requested, or there isn't an opportunity to talk about, things that families don't really know about, and you don't know what you don't know, so there needs to be a little more dialogue where families can learn about that. And that's all I mean, is the administrative burden. Just want to make sure that there's some discussion around how to make sure that the person truly is remaining at the center, which I know is OPWDD's intent. Right now, as a parent, I can, and I'm not pointing fingers, I've definitely felt differences in the level of service and the level of attention that my son and I have received over the last, year, mostly last year. But I do understand change can be painful. I'm just hoping that there's conversation around some of these things so that it can minimize the pain a little bit until we get to the other side, where data is able to inform what needs are, and we're not just giving oil to squeaky wheels, we're actually fixing the vehicle. So I get it.
So we could have a conversation about CC operations at some point in the future. That'd be great.
Cool, thank you.
I have a question. Tamika, are the staff action plans considered really part of the life plan, and is data being captured there?
Margaret, that's a very good question. I recently presented at NASDA's, and someone from Washington, D.C. asked that same question because they've been trying to figure out how to look at quality related to care coordination and care management, and they thought the staff action plan would be a great place to sort of identify that. At this point in time, no, we don't collect data on the staff action plan, but it's something that we're looking to see what we can do.
Because that's where the goals are, actually.
And NASDA's, for those of you who don't know, is the National Association of State DD Services Directors. It's our trade group. It's the 50 state DD programs that meet twice a year. And we've actually begun sending staff to that meeting so that they can network with other states and find out how things are going, what we can learn from states or what we can teach other states. So that's something we've been doing for the last 6 months or so.
Thank you.
Any other questions? No? You're all so quiet. So we have lunch on the agenda at 12:15. It's 12 now. I can't really start with the next part of the program because the presenters are not here. Do you want to talk about anything else for the next 15 minutes, or do you just want to start lunch early?
Margaret wants.
We had a whole...
It's fine. I mean, I think I want to make the best use of your time. I know you've come from, some of you from great distance. So if you want to add 15 minutes of public comment into here, that'd be fine, or other topics.
Okay. So we had a number of things that we wanted addressed. I'll try and skip the family support questions, because that should come up when we talk about the survey,
After the
right?
presentation, sure, yeah.
Okay. So, well, and the family support. Actually, a lot of them are family support. Well, the start date for the CFCOs and the EBVs?
So I think in the last public communication that we disseminated, we said January 1st, 2020, correct? I think that's what we last said. I think that's what DOH had last said.
That's for the CFCO.
Correct. And we were doing trainings with our providers to help assist them with that transition. We haven't heard that the date has changed, although we haven't heard that there's any specific activity that's been undertaken in the last few months to facilitate that change. So obviously, it doesn't look like it's going to happen January 1st, 2020. We haven't been given any advice on a postponement or a potential date for implementation. Meaning, I don't really know more than I just said. I mean, that's
Okay.
literally it. It has to happen as I'm learning more about the commitment to CFCO. There is an enhanced federal match attached to that. The state can claim a 56% federal match as opposed to a 50-50. So if the state makes a commitment to do CFCO, they get a reward financially. We've accepted the financial reward. We are now obligated to implement CFCO. So it will happen. It's just a matter of when and how. We don't know the when and how. So all the things that you're thinking about, I won't say worried about, but thinking about in terms of CFCO implementation, I would continue to think about them because it will have a significant impact on OPWDD. Okay.
What about the electronic
EBV?
visit? Yeah.
Oh, electronic visit verification. Again, that's a larger issue around the Department of Health. The federal government affords us an opportunity to apply for an extension. DOH applied on behalf of New York State for an extension in implementing EBV. I think they got a 1-year extension. We were just talking about it recently. We haven't gotten any guidance from DOH around an implementation process, plan, timing. All we know is that there was an extension approved, but we don't know more. Again, that's a very important issue for us.
Okay. And
Electronic visit verification. There was a EVV, yes. Sorry. And that's for those of you who don't know, just to clarify that, a process of providing documentation for services provided generally in people's homes, but in other off-site locations. The federal government is going to require that states have a system in place to electronically verify that those services were provided. And so for individuals and families who receive services through OPWDD, we need to have an electronic visit verification system, which probably means someone in an individual's home verifies that a service provider actually delivered a service. And then it gets really complicated after that, right?
Not just the paper that sometimes they fill out. You want something like a call, they can call back and forth?
So the word is electronic. It's no longer paper. And there are multiple models used in different states. We're not the lead agency on that process. It would be the Department of Health, and it would be applied to all services funded through Medicaid. So home health aides, personal care attendants, private duty nursing. That's on the health side. In addition to what we do with service providers who deliver ComHab and other types of supports, including programs supported through self-direction. So it's a really important issue for us.
Would that include a GPS system?
It could be.
Because I know
it could be. Let me just say that.
Yeah, because I know there's privacy concerns for some people.
Well, I understand that, and to be honest, I'm not sure I fully grasp the concern because providers who are being paid to support individuals are going to that location, and it's important that that location be documented in whatever system, whether it's a paper system or an electronic system. So disclosing who is there and the location of services, I'm not sure that those are clearly privacy concerns, but they're issues that actually need to be incorporated into whatever billing system we have, whether it's paper or electronic. I think the idea that you have someone come to your home to provide services means that you waive a certain privacy right to allow that individual in your home. It's just like you want to use Alexa, you waive a privacy right when you invite Alexa or other, voice-enabled systems to come into your home.
I think the concern is more when you're doing things that are not in the home, that are in the community, one way or another.
So it's important to know where the service is provided. Again, I don't know whether to use a GPS-based system or not.
Yeah.
There's some parents, sorry, Margaret, just agreeing with, there are some parents that won't even let when there was CERP MSCs, I know they're not, but I'm just saying, they wouldn't even let them in the house, period.
Oh, that's okay.
And that's the ones who don't want anybody to know what's going on in the home.
Well,
You can meet them anywhere but the home.
But to follow that logic, they wouldn't
agree
allow a
with that.
provider in their home. And so, if there's a service provided off-site, there still needs to be a means of documenting and capturing that data. Again, I don't know what it's going to look like. GPS-based, phone-based, landline versus cell phone. We really don't know.
I don't know that people, that some people may not grasp that if you're accepting a government service, you need to be accountable for it.
I agree with that, Margaret, but we do have parents that they want the services, they want the help from the government, but yet when you explain what has to be done, they're the ones who there are a core group that still get problems, and it's sad because the person they're really hurting, besides themselves, is their child.
On to the rest of our questions.
Sure, yeah.
Okay. So we wanted to know if there's a managed care time. What is the revised managed care timeline? Is there one?
So I can recall that in September, we received approval to communicate to the public that the revised SIP-PL qualification document would be released for public comment at the end of October or the beginning of November. So that was well rehearsed, I think, right?
Right.
I've been saying that over and over. Obviously, it's mid to late December. The document has not been made public. So I can tell you that the document has not been finalized. We received public comment from 75 or 80 different stakeholders. We worked internally to incorporate those changes into the qualification document. We also have to work with internal partners, DOH, OMH, Medicaid, and DOB, the Division of Budget, to ensure that we have their support and alignment in terms of the document. Mm-hmm. And I think at this point we're working with those internal partners to conclude the drafting of the document. I don't know when the final document will be concluded, but obviously it's not prepared, not ready right now. There is a possibility that it doesn't come out for some time. Generally, again, I'm new to state government, but my sense is that initiatives of the scope of the SIP-PLs generally don't launch in the middle of budget negotiations. It just doesn't seem to fit. The budget negotiation is about anticipating what future expenditures will be with lots of negotiation. It's very complex. The announcement or bidding of substantial and new programs generally doesn't happen during that 3-month window. So it's easily conceivable to me that we don't see more in January, February, or March, that we wait for the budget context to finish before moving on to considering a republication of that document. Again, that's the draft qualification document for SIP-PLs, and to make that available for public comment. It's not the final, it's another document for public comment.
Oh.
Right, so it's, again, more public comment, not here's the final draft based on public input. So you're all going to get another shot at it. I don't know when, and it's possible it could be several months.
Is there anything that you can tell us about what we might expect the budget to yield? I know you're in the middle of negotiations.
Well, so you all read the newspapers. I don't have to reiterate what the newspapers say, but it will be a very difficult budget year. I mean, there's 3 scenarios for OPWDD. We get more money, we get less money, or we get held constant. Given that there are significant fiscal pressures on the state, we're not going to get more money. I'm not sure we're going to be held harmless. It's very likely that we'll be asked to make cuts in certain program areas to accommodate the larger budget. I think folks have sometimes thought of OPWDD as a silo that's separate from other state programs. We're not a silo. You know, what happens in DOH or with Medicaid affects us. And the division of the budget is the arbiter of how funds are allocated. And it's kind of fluid. You know, they can say, well, we're going to put a loss here, or, you know, a cut here, or an increase there. But they basically move across those borders between, say, what we do at OPWDD, what OMH might do, or what DOH would do. And it's fungible. You know, if a program moves over from one side to the other, for example, like CFCO, we don't know how that might affect our budget, because we will be providing services, we currently provide services that are part of CFCO and might move from our organization over to DOH. So there's a lot of things that go into the decision about what OPWDD's budget looks like. But, you know, the odds are we're going to get cut. Don't know how much, and don't know how those would be allocated across programs. But that's the likelihood.
What would be some of the criteria you'd be using to determine?
We would use, or DOB? Well, so just to bring it back to family support, we've talked in the past, the last two meetings, about services that duplicate what we offer through waiver. And then we'll talk about this in the survey, but it's not news that we've discussed intensive behavioral services, for example. The fact that the council funds intensive behavioral services, and at the same time that's a waiver service, that the dollars in the council are 100% state, the dollars in the waiver are 50-50. Every dollar spent here, if it was quote unquote waiverized, can purchase twice as much service if it were put through the waiver. So one scenario is if I had to cut $4 million, one way to accommodate that would be to take $4 million of IBS services from the Family Support Council, put it into the waiver, make that $8 million, and then make the cut after it's quote unquote waiverized. I'm still going to end up net providing $4 million of intensive behavioral services, but I've also accommodated DOH, DOB, and a $4 million cut. So it might not make all of you happy, but that, in my mind, would be one way to preserve our service capacity and accommodate whatever budget constraints we have. And those are the kinds of things I have to look at, you know, creative ways to find new money. Yes, other question?
Commissioner, if your staff could send us a brief overview with some highlights, with some numbers. Like, I like to write letters to my state senator, to my state assemblyman, and to the governor. And if I had some numbers to use, I'll write letters to them about the importance of the budget.
Well, I appreciate that. What I've suggested to everyone is that individual advocacy try to be coordinated, and then group advocacy, let's say advocates for families and family support, coordinate with advocates for other services like CCOs, CIPPLs, providers, because what happens is there's a lot of noise from the advocacy community. It's not well coordinated. I think there was a newspaper report recently of downstate providers, OMH, OPWDD, and OCFS providers, and OASIS providers advocating for something that they call 3-4-5, which is a 3% across the board increase for the O's times 5 years. I didn't see representation from the Family Support Council in that. I didn't see self-advocates. I didn't see self-direction advocates in that. It was driven mostly by the larger providers. It was submitted to the chairpersons of the committees on mental hygiene, both in the Senate and the Assembly, and generated a written response from them to the budget director. So there's a lot of advocacy that's already started around the 2020 budget and going forward. I think it'd be useful for you all to understand that and try to align what you're going to do with that or not, but to take that into account in your advocacy. Does that help?
I was hoping to be even more general than that. For example, last quarterly meeting, I think you mentioned there's 120,000 people that receive OPWDD services. You know, and divide that by whatever our budget is, $4 billion. I don't know.
Yeah, but that's an exercise you can do. Number of people served and divide the total
Which
number.
exercise I could do if I have the right numbers, which is what I was hoping your folks could give us.
So I can tell you our budget is in the area of about $8 billion, and the denominator portion is a little vague. So, you know, we have a waiver with a ceiling of about 85,000. We have CCOs that support 107,000. We have about 102,000 individuals who have been identified by DOH as receiving OPWDD benefits. Going back to Tamika's question, you know, how do you define the number? There are multiple numbers. So 85, 102, 107. I actually don't know where the 120, 130, 140,000 number comes from. It may be anyone who's ever been touched by the OPWDD system, in addition to those who claim or bill for services. So the numerator is a little squirrely, you know, 8 billion or 8.5 billion. A good chunk of that are state operations and state employees. It's not always clear what I'm saying in terms of those numbers, because I don't actually have great data on, for example, the total number of people served. I can tell you number in the waiver, number in CCOs, the number who have a Medicaid number that has a 95 modifier on it. But those are three different answers. Anyway, back to my point. I think there's an opportunity for advocacy. In many respects, it's pretty far along in terms of the process. I would be looking at how you want to align advocacy for family support services with the larger context that's occurring, this 345 campaign, because that's got traction at this point. Does that help you? Okay.
That's pretty much our non-FSS questions.
That's good, because it's 12:19 and probably time for lunch. So if we can reconvene at 12:45.
Okay.
Thank you.
Okay, we're live.
So thank you for joining us again. We're going to continue with our program. Kevin Rolenchis and Aviva Kindo are going to talk about the Family Support Survey. And then I think we have time for discussion after that. Are you guys ready? Okay.
Make sure you talk into your microphone or I have to yell at you. If the people on the phone can just hit mute, I appreciate it.
All right. Good afternoon, everyone. Sorry for the delay here. I'm trying to settle multiple things. What we wanted to do is take this quarterly meeting to talk to you a little bit more about what we've, what activities have happened thus far with respect to the Family Support Services Survey that we've discussed with you, I think, the last two meetings. So the first is just some background information about the survey instrument itself. I just want to make sure everyone can hear me, right? I can kind of hear a little echo. Yep, okay.
On the phone, sorry, Kevin.
Yep, no.
I can still hear some feedback from the telephone, so can everyone check and see if they're muted? Thank you. We're going to have to disconnect the phone if we don't get a mute soon.
Okay, thank you.
Sorry.
I don't want to get on Josie's bad side ever. So I do anything she asks. So we talked about the idea of conducting the survey back in June, with the goal of obtaining some program-specific information on the supports and services that are funded through these contracts. We released the preliminary survey instrument for you, and you guys, gave us some, valuable feedback, and we made modifications to the instrument, the survey in and of itself. And we talked a little bit more about what changes had been made to the survey back in September. And after the September meeting, we finalized the survey instrument and we distributed it to the FSS providers. So that was, sometime in late September, early October. So what have we learned thus far? That's what really the next section is really here to talk about. So there are 403 total FSS surveys that were distributed to the providers during the first week of October 2019. And when I say surveys, those are also akin to the number of family support contracts. So we had a survey for each of the contracts. To date, we've received back about 90% of the survey responses. About 364 surveys have been completed and returned to OPWDD. 16 of those, 16 additional surveys, however, can't be completed because of program closure. So that's about 4%. And 23 surveys, about close to 6%, we have not yet received a response back from the responsible provider. So we began compiling some of the survey data that came through for those 364 surveys that have been returned, and we just wanted to kind of share our experience thus far with you. So across the 364 surveys or contracts, there are a total of 880 programs that were funded with these 364 contracts. You need to move closer? Sorry. You could have just pushed me. Okay. There's a lot of rules. So, again, as I was saying, for the 364 surveys / contracts, there were 880 different programs funded throughout. So that just means that many of the family support contracts fund more than one program. And what we've done in terms of central office activity thus far is our staff have taken these 880 programs, and based on the descriptions provided by the FSS provider, we tried to categorize them into general themes. And we did vet this, I think, with program folks in terms of the overall classification before we really began completing the survey classification. So I know this is okay. So this table is really intended to show how the themes, if you will, the program type is what we're calling it, the program type or theme. I'm sorry, I turned my head. How we classified each one of those, or the major themes that we used to classify each one of the surveys. And we did that allocation, so you'll see the next column is the total dollars allocated to the program. And it totals $56.5 million. I know it's hard to read, so I'll try not to turn my head. We have the vast majority of the dollars are related to family reimbursement, and we can talk a little bit if you guys have questions about these. That's why I have my program friends over here to help explain everything. Family reimbursement is the biggest, around 23% or $13 million. Training is about $9.3 million, about 17%. Respite is about $7 million or 12%. Recreation services are about $6 million or rounded up close to 11%. We have crisis intervention services that are about a little over $5 million or 9%. Information referral and or outreach is about $5.5 million, again close to 10%. We have service coordination, care management, case management at about 7%, about $3.8 million. And I'm going to skip other, which is another big classification, but it's because other is kind of the catch-all for everything that's not identified, in these themes. We have an advocacy spend of about $2.1 million, 4%. We have transportation of about $1.5 million or 3%. And then we have counseling and support groups, about a little less than $1 million, or about 2%. Anything that's not in one of these major themes is kind of lumped into other, and that's why the other category, at least illustratively, is a little big. Is about just over $2 million, again, about 4%. So again, these are kind of the major themes that we decided to use as a way to classify the 880 programs across those 364 contracts. I think that, if you're to talk to a statistician, we've got a pretty good sample size in terms of the survey response rate. I mean, 90% is pretty good and would be illustrative, to make inferences even across the remainder of, those, I think, 23 surveys I said earlier that we have yet to receive back. But, I think we've gotten a good response rate and appreciate the, the collaboration and working with the providers, the RO and you to get, to kind of get to this point. So that's really just kind of how we've classified things. So again, I think it's representative of what we see on a system-wide basis. So what does this really mean? So we have some, I keep turning my head. Next steps. So we continue to work with, here in central office, or back at 44 Holland, we're working with Abiba, Jackie, Sally, and their staff to review the preliminary categorizations, those that we just kind of walked through, to make sure that from a program perspective, they agree with how we've classified each of these, when I say programmatic perspective, with how we've classified each one of these 880 different programs that came back for those contracts. And we'll make adjustments to that final tally as necessary, and that's still in the throes of ongoing activity. We're also going to work with the FSS providers to clean up variances between the total program costs and those reported, the reported component costs. I think I didn't address a bullet that was on the chart slide, but what that was really saying is that from a survey perspective, the total that was included in the contract value didn't match the pieces parts, like the NPS, the PS, and the other costs that are funded by the contract. So that clearly needs to be cleaned up, because the total contract value should match its pieces parts. And then what we want to do is, we think that with the next quarterly meeting that we have with you all, we'll be able to actually present our findings on the survey data, in some more detail than this kind of higher level conversation. So I think that's really, what we, I don't even have an end slide. So that was really, the end of the presentation, just to kind of give you guys an update as to what we've been doing. I think, as you can kind of glean, it did take some time for us to get the survey responses back and compile all the results. Going through those 880 programs was a very time-intensive matter, and I really appreciate the effort that everyone has put forth to not only complete the surveys but review it, send it out, complete them, and then summarize those responses on the back end. And Margaret.
Where is behavior?
That'd be great.
Where is behavior management in there? Did I miss it?
I think that in crisis, right?
Yep.
It would be in the
That's
5.
in crisis.
Yep.
Okay. Thank you.
We had a little discussion before you came about budget in general. If, for example, division of the budget recommended that we have a cut, how would we cut services? How would we prioritize? And, my comment was, we don't want to cut any services. So we have to find money. If we're asked to reduce our overall state spending, we have to look for new money. And I said, the new money is waiverizing services. We make money by matching. And then so that led to this discussion, kind of a continuation of the theme that we had over the last 2 meetings of, why take something that's in the family support services budget and move it to the waiver. It's because if that 3 or 3.6 million of, it's 5.2.
Yeah, 3.8 for service coordination.
Right.
All those different
numbers. But those two, the crisis and service coordination, we have systems in place. I'm not saying that they're optimal, that they're doing everything that they need to do. we have to make our systems work as well as they can. But we have a crisis response system that we're looking to strengthen, and we're looking at trying to strengthen our care coordination and service coordination components. So those two kind of jump out at me when I look at opportunities for reducing state cost and preserving services. I don't want to cut services.
And respite.
I don't want to take the whole thing.
But I mean,
there is a respite component in our
New York
waiver.
City is all respite, almost all, maybe 99% of New York City respite is waiver.
I understand that. I'm trying to be sensitive to the fact that there's a degree of discomfort about the idea of waiverizing the entire Family Support Council program. So let's just take some baby steps in that direction and just talk about the crisis response system that we're trying to work on and the transition to CCOs to deliver care coordination and how that overlaps with Family Support Council funded programs.
The reason why we are concerned and upset, I'll make this quick. When it comes to the care coordination, or what used to be known as non-Medicaid service coordination, was an excellent program to get the parents in to get the Medicaid waiver, because it's a much more, it's easier to do it that way, because we can't go to a Medicaid office in New York City and say, my child's with a disability, I need OPWDD services. They have to go to an OPWDD provider to assess if the child needs it. In reference for the crisis, many of our families wish we had something similar to what mental health has. You don't even have to be known to the system, but you have a crisis, but we want them trained in DD ways. When our children go, as I will quote one of the EMS workers, says, when your child goes bonkers, what do we do with your bonkers child? But I would say, so we need to you need to understand why these programs were family support. And also one problem, you waiverize it, then I can't visit it. And that's unfair, because when the former Commissioner Moll started waiver, he put a clause in that it was family support-like programs, and we were still allowed to go and do site visits with a state worker. I didn't say by ourselves, but with a state worker. That's not fair to us. That's the other issue, why we're concerned.
I totally understand that. I'm not saying that these programs aren't valuable. They are. I'm saying that when we sit down with the division of budget, we will be asked to make trade-offs. One program against another, against another, against another. And DOB is doing that with us because they're saying to OMH, OPWDD, OCFS, OASIS, and DOH, the Medicaid programs, we're going to trade one off against the other. We're going to find ways to match
that, but you do have to make them understand the part where we make them understand. So when I advocate, I say why the program is important. Because with crisis, I tell them straight up, look, my child's not bunkers. If my child has an issue where there's a crisis, mental or emotional, they have developmental disability, and that needs to be acknowledged. And since most of the parents are either legal guardian or have the New York State Healthcare proxy form, they have the right to talk to the provider. And they play games on us. That needs to be changed too.
I don't disagree with you.
I understand what you're being put through,
Yeah,
but I'm
well,
saying
I'm
we're
just sharing that.
I appreciate that.
I want everybody to understand.
I understand.
Because I don't want what we do to appear to be arbitrary or capricious.
I understand. You still have to answer to Governor Cuomo. We do understand that. He wants to save money, but he also needs to understand how you want to save money one way, you may be spending more money in another way.
It's not a Governor Cuomo issue. It's not an issue of saving money. We added 7% more people to OPWDD's roles last year. No one got a 7% increase in their budget. So I have, 1% or 2% more in 2019 to spend than I did in 18, but I have 7% more people than I did the previous year.
I understand that.
So that requires that we look at our current budget, the portfolio programs, and we will have to make trade-offs of one against the other. So two things I really hate. One are waiting lists, and the other are service cuts. So we don't want to have waiting lists. We don't want to have service cuts. How can I make money? I don't have a printing press. I wish I did, but I don't. I have a checking account with a lot of zeros on it, but it's still a fixed amount of funds to support whatever number of people we support with all the programming that we have. So I can make money by going to the federal government and creating or expanding the capacity of programs through the waiver.
But then we lose the ability to do the site visits. That's very unfair to us part. That's the part where...
So this is what I said to you all 3 months ago. Help me understand the relative value of $1 spent through the family support program versus the $2 that I could spend if it was waiverized. That's a trade-off, right? Family control and input is desirable. And so is serving twice as many people. I can't do both. I can do one or the other.
I understand that, but the part with the the part I'm only saying with the waiver is that we as the council members were told we were supposed to be allowed to do the site visits even when the program was waived. It was in there. If you go back to you look at the past minutes and records from when Commissioner Moore was the commissioner. That is how he got us to agree. And yes, we council members across the state did do site visits to those programs. We don't want to lose our oversight. Not that we want to make sure that we can still go and visit these programs and check, because when parents complain to us, they feel more comfortable a lot of times talking to a parent.
That's
and that's
different
the
than
issue.
what
So,
we're
Commissioner,
talking
if I
about.
can just address that for a second, because I think Deb and the other council members know that this was an issue that we had worked on, and I thought that was resolved. We worked out a process with DQI to allow interested council members to continue to visit programs. So if there are outstanding issues, we can certainly talk about that
Sure, but it's
offline.
a different
But we had addressed that. So I just wanted
Yeah,
to
I
make sure
understand.
that
No, I'm saying if you waiverize these new programs, that's the issue.
So
If you waiverize, then how am I going to still advocate and have oversight as an advocacy part? That's
so
the
we would
issue I'm
be
talking about.
applying the same provision that exists now to any future waiverized programs. We can talk about that.
Like, I don't want to talk about respite, okay? Because I know this is uncomfortable. I know this is new, but I can't resist the opportunity to not talk about crisis or care coordination, service coordination. And we've talked a lot about CCOs. I think you all have a pretty good understanding of how the CCOs function and operate and what we've done with contracting over time. But you probably don't know much about the crisis response system that we have, the START program. I don't think we've talked about that.
I do know about it.
Okay, but not everyone in the
I
group.
agree.
So let me just give you a kind of a higher level view of the START program, our crisis response program, so that you can understand how it might relate to the crisis response function that's funded by the council. We don't have a very good continuum of care. Let me start with that. We have folks who live at home with their families, who have a crisis. It's often a behavioral crisis, and the family doesn't have anywhere to turn to. When you had your MSC and now a CCO, there wasn't a service or a program that you could be directed to provide behavioral services or some other emergency-related clinical response. So folks would go to the ER. Folks would be held in ERs for long periods of time. They would go to hospitals and be hospitalized. And families had a resistance to take their loved ones back home because they didn't have the support in their homes to care for that individual. And so before crisis response, this was really important. This provided a service that wasn't accessible through the OPWDD system. Now, we have intensive behavioral services. Intensive behavioral services are kind of blended into the rate structure for residential providers and day program providers. But there's no rate for families. it's a standalone program for families. We have 20 or 30 intensive behavioral service providers who are credentialed and approved to provide services. And they, in total, provide about $200,000 of support statewide. The first time I told someone that number, they looked at me like, you mean per person? And I'm like, no, 50,000 people who live at home with their families receive in total $200,000 of behavioral services. That's why you guys are funding it, because our system doesn't work. We're not providing the right service in people's homes to support families that have children and young adults with challenging behavior. We have to fix that. Part of the fix then was to build a crisis response system. It started 3-4 years ago with a contract with the University of New Hampshire Center for START Services, and OPWDD began funding a crisis response system, a team that would go out and assess people in crisis, usually behavioral crisis, sometimes medical. We have a crisis response system, a team in our Region 1, 3, 4, and 5. We actually have 2 in Region 4. So we're building out a statewide system of crisis response. As part of that, we also include a resource center. So each of those regions will be supported by a 4-bed resource center that can provide an emergency respite type setting where clinical services can be implemented in the hope of stabilizing the individual and returning them back to their family. We need to make IBS work, because if we discharge people from our crisis response program, from the START program, if we discharge them from a resource center or a crisis respite program back to the family, we've got to have services that follow along. So we've looked at, actually I looked at the IBS rate when I was a provider at Montefiore. It was too low to create a viable business. I think part of the problem with IBS is our providers aren't being paid enough because of the requirements for travel, documentation, non-payment for missed visits, and things like that. We have to look at IBS to be sure that it works and it's accessible. We actually have to expand it, increase the amount of money we spend on IBS. One of the things about our crisis response system is that it's 100% state funded. It's on the order of $20 million, 100% state dollar. So the rule that I've kind of made up and shared with you, that we have to find ways to waiverize services, is we're applying that to our crisis response system. We've split the START program into 2 components. There's a clinical team component, and some of you are familiar with that. That's the group that goes out and does the emergency response, tries to provide services, stabilization within a certain number of hours. That service we have applied to CMS to create an amendment to the Medicaid state plan, which would make it reimbursable through the Medicaid program, which means that if we spent $10 million a year on the crisis response teams, it's only going to cost us $5 million. I'll save $5 million in crisis response, which can go to the division of the budget if they demand that we make service cuts. I can preserve the program and free up additional money. On the crisis respite part of our crisis response program, we believe we can use the existing authority in the waiver to fund individuals who need a clinical setting, which is an intensive treatment setting, but one we can consider to be respite. We can build that under the waiver. If that's the other $10 million of our crisis response system, we can save $5 million by waivering that. So we're looking at both elements of the crisis response system: the clinical team that does the outreach, the resource center that provides the intensive respite, to waiverize both and reduce our total spend from about $20 million to $10 million. We're going to use some of that savings to expand the capacity of our network. We don't have a team in Region 2. We don't have a resource center in Region 3. So we're looking at taking some of those savings, reinvesting them in services, ensuring that there's a statewide system and network. So that's kind of the high-level overview of what we're doing with our crisis response system. But because we have two systems, we have a care management system and we have a crisis response system. For me, the question is, what do we do with $9 million or so of dollars coming from the Family Support Council to providers? And what's the trade-off of that? You know, that serves X number of people. If we waiverize it, we can serve 2X. And that's the kind of trade-off that I think is worth having a discussion about. I don't want to go into everything on that list. I understand this is uncomfortable for a lot of you because you're strong advocates for families and the family support councils. But I'm going to have to make trade-offs. And this is a way of preserving capacity, which is critical to me, you know, avoiding waiting lists, preserving services. So I didn't make that easy for you, but that's kind of, it's not easy for us either. You know, we care about families and individuals. We want to do the best with the resources we've got. Sure.
I've been through the crisis management system, the IBS and New York START, and I, experienced different impressions. And there's some bumps in the system, but I think it is critical to have that crisis support out there for families, because you can't access even any other supports if you can't manage behaviors and provide a safe environment within your home and in the community. So, to me, it's a bottom line. I think for you to explain it, and that, at least for me, it gives a better perspective on where you're looking to go with the waiverize. That there is a kind of a plan. This is not something out there to give money away, but the money is going to be used for really to support families.
The big picture for us is we've got to have a continuum of care that operates and can support people at every level across that continuum. So we actually need to figure out how to support families in their homes, primary care providers, mental health providers, provide intensive behavioral services, crisis response, crisis respite, before people move up the continuum to ER, hospital, state psychiatric hospital, institution, and then come back to us and say, we've used every level, now we need a residential setting. We have to find ways to help people move down the continuum and be supported where they live with their family. So it's kind of self-serving to build that continuum, but this is part of that bigger picture. You know, there's a plan here. It's not arbitrary or capricious. It's building capacity to support families at the lower level. And I know that's what you're doing too. So it's not like we have a different vision. Sure.
I defer. Hi, Commissioner. I think it's great. I'm hearing you talk about some plans and somehow some of the pieces are coming together. I'm familiar with START. I'm from a region that is very rural and not able to reap all those benefits as of yet. Will probably be last in line, but conversation around behavior support services has been plentiful in my neck of the woods with family members, with other providers. And I just, as a parent of an 11-year-old son who receives services, I wanted to share just a few things about concerns around the behavior support in hopes that, again, these things are being discussed and considered on behalf of folks with disabilities. This is actually a picture of my son, because he's super handsome and wants to be on TV. When he was 11 years old, this is the age that he was when I got a call from his school psychologist telling me that he was suicidal. I'm speaking today as both a parent and a provider, or someone that works for a provider. The most important, of course, is being the parent. My son, his name is Christian, and he struggles socially. He needs support and reminders to do lots of things that most people take for granted. But he has a very brilliant mind. But he really struggles, and those struggles intensified when he got into middle school. He'd crawl under furniture, rock back and forth, communicate through blinking, and refuse to do work. I literally changed careers because I didn't know what to do for my son, in hopes that I could learn more and find out other resources. We literally went through 2 mental health intakes for my son that were grueling, several hours long, only to be told at the end of them, oh, we can't help you. You're pretty much overinsured is the message I got. He's OPWDD eligible. And we didn't qualify for services. We were even told, if you really are worried about your son, take him to the ER. You can do that, or maybe you could consider a residential school, none of which were options for an 11-year-old. We didn't really know what to do. We learned about OPWDD behavioral support services, and we didn't really expect miracles, but we were able to meet with a provider almost instantly when I shared the concerns and what was going on with my son. The behavior specialist that worked with Christian taught him strategies to cope with his emotions differently, while my husband and I learned amazing tools that we could use to help better understand Christian and advocate for him. And so we only met with the behavior support specialist a few times, and this was an OPWDD FSS funded behavior support specialist. And we didn't require hours of formal assessments, teams of doctors. Certainly we didn't need a residential placement. FBAs that could only address a few behaviors at a time, or lengthy BSPs. We didn't require all of that. We needed a quick response, and we needed a willing ear and someone that could just come to us in our time of paralyzation, for lack of a better word, and just help us understand his behavior as a form of communication and give us some encouragement. And that's exactly what FSS OPWDD funded behavior support did. It literally saved my son's life. And I say this because I've heard far more threatening stories and sensitive stories about physical violence and families, parents being physically attacked, or self-injurious behavior, near constant screaming, spreading of feces, all sorts of behaviors that parents are struggling with. But a lot of these folks aren't yet enrolled in the waiver. And some of those folks wouldn't even qualify for intensive behavior services as they are now, and they're in desperate need of support. And so some of the questions I have that I'm hoping you'll consider, and I have a piece of paper that I'll leave that has them on there. You don't need to address them now. In fact, I'd rather have another conversation after you can, kind of put some thought into them, is just getting an understanding about a little bit more about what's driving some of this discussion. We're very quick to talk about behavior support and that it's duplicative. I'm not good with that word, but it's a duplicate.
If you say it twice, it's just as good.
There you go. Because on paper, I can see how it is. But in process and in experience, it really hasn't been. So I'm curious what other than finances are driving the change, and what data the team maybe has collected that demonstrates that cutting this service is not just going to save money in the short term, but in that long term too. And how deep is that analysis, and what kind of savings? I mean, you did address some of the savings that we can expect, but I think there's a ripple effect that we need to consider as well. It seems to me that this type of a service could definitely have a significant ripple effect on so many other things that include longer waiting lists, which you yourself have said we don't want that, that include a rise in hospitalizations and displacement while waiting for services and additional stress on families. So if people need behavior support, and they'll have to be approved for waiver services, which is a lengthy process. It's a delay, it's a kink. So not all families need or even want waiver services, which of course come with additional expenses, Medicaid coverage, care managers, and so much more that not every family wants to be a part of. So how can we justify shifting these families to this model and spending money and resources that the families don't really want or need? Won't this increase numbers, make it more difficult for CCOs to serve the individuals that need the services? And then if the services are shifted to waiver, what behavior services, if any, will be available for people that don't yet have OPWDD eligibility, that aren't or have eligibility and are waiting for waiver service approval? These things are important because, as I said, they take time. So behavior support services, if any, we need to have something available for people with scores below 50 as well. Assessments, we're noticing, are not always as accurate, and as you said, without the right models with consistency, they're kind of all over the place, so a score might not be a fair assessment at this point in time. So during previous discussions, I think I gained most anxiety when I'd asked the question, what are we going to do about these folks, and how are we going to change guidance and ADMs to make sure that we're really meeting the need? And the response was, those things take time, and they might not be done yet by the time we move on this type of a decision, and that's where my anxiety kind of grew. Because since managed care is all about saving money, improving outcomes, reducing hospitalizations, not taking the time to explore that, to me, could result in something very counterproductive. So again, I'm just curious, one of my biggest questions is how is that going to be addressed? And then there's the additional paperwork of IBS that requires lots of, FBAs, functional behavioral analysis, just for billing to be completed. And as I mentioned earlier, when sharing my family's experience, that wasn't even something that we necessarily needed, and we got over that hump. And so that is spending hundreds more dollars and tying up a lot more people's time that isn't necessarily needed. So it's really around justification and how is this a good use of funds and professional time, which could be used truly to support additional families. And then how can we justify the waiting list? Because IBS does take longer. You work more intensely with a smaller number of families. Additionally, you mentioned IBS providers and that there were 20 to 30. There aren't a ton of them around. I'm curious if there's been some research and data collection as to why that is. You mentioned a rate. Yes, the rate is definitely a concern. Are there methods and approaches that are going to be used to ensure that there is enough IBS providers to meet the population's need? And is there a proactive plan to ensure the need will be met with this model? And is there data that you can share in the future as to what's kind of dictating all of that demonstrates adequate coverage can be assured? Because IBS is time limited, it doesn't allow providers to offer a fade of supports to families, which I think is a really crucial thing because, not everything is fixed with a switch. And does OPWDD also have some success rates that are informing this for when reinforcement schedules change after the program ends? Because that would be really interesting data to get an understanding of. So somebody also mentioned mental health, and I think there's a lot we can learn from mental health models because mental health services for children recently moved to a waiver model. And there's no more non-Medicaid mental health services for children. As a result, there's lots of families suffering that can't get the services that they need. So I'm wondering, what does this model inform us? And are we taking some information from that can help us avoid the same issues? So it's really around how we're going to make sure people are getting what they need. I just want to mention my son is not the only one. I'm here representing many, many families in my region, folks that I work with, folks that are colleagues of mine through the Family Support Council, and just other parents that I happen to be friends with. And there's a young man, his name is Tom. That's not really his real name, but we're going to call him Tom today. And he really had far more intensive behaviors than those that my son struggled with. That included stealing. He physically beat his family members up on a regular basis, lots of violence, threatening his peers, suicidal and homicidal ideations, accessing pornography at home and school, sexually inappropriate behavior. The list goes on. Yet this young teenager somehow did not qualify for intensive behavior supports because, and this is a quote, he wasn't homicidal enough. And that's a very concerning statement. And goes to say we need to make sure that the people that are assessing need, I'm curious who those clinicians will be and how they're going to get the true scope of the family dynamic as well. But his family was literally about to institutionalize this young man, and he was able to work with a program that was OPWDD, Family Support Service funded behavior support. And again, his family learned about controlling emotions, controlling impulses, consequences, recognizing, the antecedents to his behavior. Very, very valuable information, and it was timely, and it was responsive, and it was ongoing with a fade. And I feel confident when I say that family support does save money, both in the long term and the short term. And it keeps families together and saves lives. And I do know this personally because my son, yes, bragging again, is now 15. So this is him at 15. And he's still here. He's still on this earth. He's living with his father and I. He's now attending his home school because he was placed in another school at one point when nobody knew what to do. The behavior support specialist really was instrumental, the one that was funded through FSS that got immediately responded to us, was instrumental in helping bring him back home. Much cheaper, he's much happier, and that was about 3.5 years ago. So I am going to leave you with a handout with some of the things that I just brought up today, and I also did a comparison from what I understand differences between OPWDD's funded behavior support services and IBSR, and I just would really look forward to getting some more commentary and information and input and understanding the data that's driving the repeated picking on behavior supports that I'm hearing, but I do understand what you're trying to accomplish. I do. And I understand that we need to trim some fat somewhere. I just want to make sure that where we do it isn't leaving a gap that really compromises everything that everyone's trying to achieve in the end, especially when it comes to displacing family members, mine included, because he's home, he's happy, and it was because of family support services. So thank you very much for listening.
Thank you for your story, and you're right, he's a good-looking guy, so I'm glad he's doing well. The goal for us would be to achieve exactly the experience that you've received through the family support funded intensive behavioral services program. That can be a benchmark that we have to try to meet or exceed. We shouldn't throw that baby out with the bathwater. So, I've looked at our referral processes. They're not conducive to accessing services in a timely fashion. I understand what you're saying about the overhead of making it a waiverized service, and not everybody would benefit from that. And we can use state-only dollars to support people who can't participate through the waiver. We're doing that right now with our crisis response system. It's 100% state funded. When we move to using either state plan or waiver services, we don't want to make waiver eligibility and OPWDD eligibility a barrier to accessing services in a timely fashion. So I've said to folks, it's already 100% state funded. It doesn't matter if everybody can't get access to Medicaid or the waiver. We're already paying for the whole thing. If 50% or 75% or 90% of the individuals can access Medicaid or the waiver in a timely way, great. If they're already OPWDD eligible, great. But we're not going to say, well, the 5 or 10% who need to become Medicaid eligible, OPWDD eligible, or waiver eligible can't be served. I mean, that would be self-defeating, self-destructive. It wouldn't support everybody. So I think what we need to do is to take the materials from you and try to use that to help us create a program that replicates as much of the quality and access that you've described, but allowing us to match it when we can so that we can improve our revenue side. But we don't want to, destroy something that works and addresses a need that we didn't recognize we should have fixed. So my hope is we can build upon the experience of what the councils have done and make a program that's better and more responsive and more timely. I've already told folks I don't like the referral processes that we have. You can't respond to a crisis when the first question is, are you Medicaid eligible, are you OPWDD eligible, or are you waiver eligible? It doesn't work. And setting out a 2-3 week process to go through all those hoops before a clinician ever shows up is too late. I totally understand it.
I appreciate that. It sounds to me like there's been
Microphone. They want you on the mic.
a lot more thought has been put into this over the last 6 months, and I really appreciate that, and I'm looking forward to hearing more developments. And I hope you did get the handout that I passed down, because that has all the points and points that I brought up today. So I look forward to your responses in more detail in the future.
Okay, it's really timely because we're looking at the crisis response system. We're looking at maximizing federal reimbursement of both our clinical teams and our resource centers. And this is the perfect time to be talking about intensive behavioral services at the same time. Just to say a couple more things. We are spending a lot of time with mental health. They actually share the same building that we do, 44 Holland. So we're meeting with their commissioner, with their executive deputy, to talk about how our programs interface with them. And we've kind of put the START regionalization on hold for a moment, so that we can talk with OMH and say, how are people in New York State accessing crisis response services? Are they using your your door, your 800 number? Are they using ours? How do we coordinate at the very point of intake so that a person receives the right service, whether it's from a PACT team on the OMH side or a crisis response team from OPWDD's side, and to be sure there's no one left in the cracks and falling through, that we don't say, he's not one of ours, and they say he is, and the person suffers because neither one wants to be responsible. That's a perfect use of state dollars only, to say, yeah, the person looks like they're going to be in our system eventually. We'll front state dollars, pay for crisis response while we access Medicaid, OPWDD eligibility, and the waiver. There's places where spending state dollars really does make sense. So we want to make sure that when we build a system, we're coordinating with OMH. It's seamless. There are no cracks for people to fall through. And then if folks drop down through PAC teams into OMH's system, it's fine. If they access our crisis response teams, drop down through OPWDD and the waiver, that's fine too. But nobody should be left without a place to go for services, and those services should be effective and they should be timely. So we're having meetings with OMH to be sure that that works. There are also discussions within the chamber, which is the second floor, between OMH, OPWDD, OASIS, the substance abuse people, and OCFS, the foster care system, about children 0 to 21 and how we coordinate providing services across those multiple agencies. That's a big problem. There's always the question of like who's primarily responsible, who's secondary. We're just trying to find out ways to work together. It's not easy. It's a little bit uncomfortable. But we want to make sure that we can provide a comprehensive set of services to every child, whether they have a disability or not, whether they're in one system or the other. So we're having high-level discussions around that. They need work, and I think your input's going to help us quite a bit. So we'll have more detail as we get closer to, operationalizing things. Okay.
No, actually, you already answered the question. The people on the phone or whatever the hell they are communicating with me, but their concern was about folks in crisis who are not in the waiver, and I think you've addressed that. That going forward, they would not be forgotten.
If our solution is to destroy the good things that you've built, that's really not a solution. So we've got to preserve what you've built, because you grew it because of our failure. If we're going to take funding and try to waiverize it, we should learn from what you've accomplished. And one of them is to be timely and to create a comprehensive system that gets services to people as quickly as possible. So we're looking at everything in our redesign around crisis response to ensure that that's the case.
Okay. Underscore one of the points that Gail made, which was that the two programs, the state IBS and the waiver IBS, are quite different. And there are many advantages to the state side. And
state meaning the Family Support Council funded. That's what you mean by state?
Yes.
Yeah, okay.
I meant state dollar. Yeah.
Yeah.
Yeah, right. So then I just wanted to make sure that you're going to explore that area particularly, so that when you waiverize, you don't leave people out.
So, I don't know if you realize this, but this is where I spent 35 years in clinical practice. So, as a physician, I was a primary care provider. After a couple of years, I added mental health to my practice. A couple more years, I added neurology and seizure management to practice. After that, we went after waiver services. We were a crisis response provider in New Jersey in 14 counties. We provided waiver services across the entire state around behavioral supports. So, my personal experience has been integrating physical health, mental health, seizure management, and behavioral supports. And, I was on call 24/7 for about 30 years. So I've been to many, many people's homes in New Jersey, Arkansas, and the Bronx. I totally understand why this is important. I mean, if you have kids, you can't not understand how behavior management is important, whether they have disabilities or not. It's really important to me that parents can function, that they can get a good night's sleep, that they feel safe, that they have skills that they can deploy to support their child. If we fail at that level, our system will not work. It just won't. We can't buy our way out of those failures. There aren't enough ER visits, hospital beds, certified residential settings to overcome our failure to support people in their families' homes. And that means supporting parents and giving them support and skills that they want to actually deploy in their homes. So we don't want to throw out the good work that you've done. We want to find a way to capture that, expand it, extend it, and increase the capacity of the program. So, and you'll tell us if that fails, then you'll let us know, and that's a good thing. So we'll talk more about it as we go forward.
Thank you very much.
Hey, Commissioner, is the housing advocacy under the advocacy or it's under other?
I think, as Kevin said, this is fairly primitive data. Like, remember we talked in the beginning about CCOs. We had a whole system out there and we didn't have any connection to it. We had to survey CCO providers to find out what percentage of individuals had life plans. CCOs is a big program. It's a $500 million system. We have to build an IT system to collect data, to be able to understand it better. And even though it's a $500 million, it's easier than managing the family support contractors. There's only 7 CCOs, and they all share the same IT platform. This system is much, much harder to manage because there are 400 or so contractors, and there's 800 and some odd programs, and none of it is electronic. So we're doing surveys because this is the only way we can collect data. And, it's great that you guys did it. It's extremely valuable to be able to take a step back and say, here's how $56 million is spent. That's great. It helps all of us understand what we're doing. But it's really hard to drill into the 400 providers and the 800 programs because there isn't any data. It's all at the level of the specific program. So we're making some inferences based on what you're telling us or what the providers are telling us about what actually is in advocacy or what is in transportation.
The reason I'm asking is because of housing advocacy, my family, we're not homeless. Because unfortunately, landlords like to pick on people with disabilities, or especially developmental disabilities, and I'm saying only that way because this is what I was suffering with. And they couldn't wait to evict us. They lied about us, claiming we never paid rent. Thankfully, the Brooklyn has changed their housing court, and they also allowed my housing advocate, which is really my son's, to stand with the lawyer they gave us. And they talked, and they saw that I was always paying rent. They just were picking us because of disabilities. And I'm not the only one, but I was willing to stand up and advocate. So they didn't like that. But that program has been a lifesaver, not just for me, for also a lot of our families who live in the NYCHA buildings. They go in there, and NYCHA constantly tries to figure a way to evict, and their housing managers use the developmental disabilities against the individuals, and the harassment and the horrors that they've gone through, I can't even begin to address. So that's also another important program. I will tell my families to write to you an email so you'll understand what the help is.
No, I think the family support programs are great. And look at it this way. You have much deeper connections to the community than we do. We're this giant organization that kind of lumbers around, tripping over things and just barreling through like the bull in the china shop. We're just really big and kind of awkward. You guys are very, very small. Compared to the $8 billion portfolio we have, it's $56 million. It's a very small, relatively small amount of money. But what you do is you deploy it in ways that gets to local needs that we can't even see. And that's what makes it such a great program. what I'm trying to do is to say we recognize the value of these programs and what you accomplish. You're reaching an audience in a way that we don't. What can we learn from you to now bring back to scale to make that big lumbering organization more focused and effective in the way it integrates services? So because we have systems around case management and we're building out this crisis response system, those two seem like reasonable opportunities for us to take advantage of what you've learned, bring it back to OPWDD and try to implement it at scale across our entire organization. That's why I'm picking on those two. It's not because what you do isn't great. It's exactly because what you do is great. And it helps us understand what the needs are in ways we can respond that we don't right now.
I thank you for that. And
Okay.
yes, you will be hearing from my families.
I'm sure, and I'm happy to.
Yes, so we'll give you information.
So back to our questions
Sure.
that we had solicited. In at least one instance, there's a situation where family support money was not spent. It's unspent. And so the question is, can that money be reallocated? Can there be an RFP or something?
I don't know. Can you?
I mean,
answer that?
we're waiting to complete the survey results to make sure we understand how each of the programs are being spent before we reallocate the money. Because right now, unspent money that has been awarded previously to providers would translate into a new spend for us. It's not like that's already factored into our cash projection. So if we were to reallocate, re-RFS before the survey in and of itself is done, not sure what programs would be awarded, but what'll happen is that'll drive up, our spending as well. So we're trying to get a sense of what we're doing with the current money before we reallocate anything.
But would it be kept in the same region? That's the issue. This is a small area, this is the North Country, and it's $2 million something, $2.5 million about, and they're concerned about losing that resource for their families.
I think I understand the issue. So, like, the money hasn't been spent. Typically, end of the fiscal...
It had been awarded but not spent.
Right. So typically, end of the year, unspent funds go back to Treasury, or at least there's no unspent funds because it's all back there anyway, right? So that money, it doesn't get spent, it doesn't get spent.
Yeah, but...
It doesn't get carried over.
In many cases, we've been able to reallocate. We've been able to say, this program can't use the money, but this other similar program serving the similar need in the region can use it, we can transfer it over there.
Let us look into the specifics, because I don't know if
Okay.
this was money that was pulled back from an underperforming provider, or if this was money that had never been spent. I don't think that we've issued an RFS recently, so when you say awarded, I just want to sort of understand the specifics behind that.
Okay.
So let us look into that. This
Okay.
is Region 2,
It's
right?
Sunmount.
Sunmount?
Yeah,
Okay.
but generally, if money's
Agencies
not
had
spent,
closed or something.
it's done with. They can't carry it forward into another fiscal year, right? It's not available anymore. But the base doesn't change for the future. The base is still the same, right? So let's say of the $56 million, $2 million wasn't spent. Well, that only means 54 was spent. The other 2 was never spent, but it doesn't get carried over into the next year. It's not 58 the next year, because we don't have 58, we only have 56.
But you
But it-
still keep the 56?
The base is 56 every year, right? The base in our budget projection is 56.
Mhm.
So
But
every
then-
year, a program could be funded if it met all the,
Yeah.
criteria around the contract. The base continues each year.
I see.
Yes, go ahead, please. Okay, so I'm going to just say that again for the people on the phone who are listening but couldn't hear you. Your point was that there was funding made available to a region, but those funds were not spent and then those funds are going to be taken away.
No, the agency is giving back their full family support program. They're not going to use the funds in the future either. They're stopping funding family support programs. So the money will go back to the state if we're not allowed to reallocate or RFP it to another agency to provide the services to stay in our region.
Okay, so I think I'm getting it. The point is that, again, an agency is not going to spend the money, and it's because it's not being spent because they can't do an RFP, it's going to go back, and the services won't be made available. Is that fair to what your question is?
I think you got some of that. The fact is, it's not that it's not going to stay with the agency. The agency is not going to do family support at all.
Right.
They're stopping their family support programming money completely.
Right, so an award was made to an agency. They're no longer going to provide family support services, and as a result, the money is unspent. The fiscal year for New York State is April 1st to March 31st. Typically, unspent funds can be reallocated, but they can't be obligated past the end of the fiscal year. So if you were to try to figure out what to do today in the middle of December with unspent money, and it involved putting funds out to bid, it's not likely that you'd be able to spend those dollars between now and March 31st. So dollars that are not spent in the current fiscal year, they don't get spent, those obligations return back to the Treasury. But going forward into the next fiscal year, the base is still intact. There's no cut to the budget. So if there was an opportunity to rebid or somehow reallocate funds into the next fiscal year, that's a different issue. But that's
That's the question.
Yeah, and I think what we need to do is, so you saw, so you guys, there's a lot of rules here. I clearly have.
It's
issues.
a waiver service. What
It's
can I
a
say,
waiver
right?
service. All right. So let's take a look back at the chart. Like if I can go back to the where we talked about of the 403 guys here, 23 survey or 16 could not be completed due to program closure. So Margaret and others, it sounds like what's happening is that's probably the instance of these Sunmount contracts. So like Abiba said, let us take a look at that and just see, what's happening here. Because I'd like to understand why the providers are surrendering, the family support services contracts as well. Is I presume there's still a need for the services in the region, right? Because we had talked, I think, a few minutes ago about, looking to award it to a provider that could deliver similar services. I just don't know why they would be surrendering, the contract and the program and just stop delivering the services. Does that make sense? I mean, because I think
Yeah.
that we want to make sure that
Absolutely. I think and then looking at the services that were being provided to understand capacity and also regional needs. So it's something that we can look into fairly quickly. So just give us the opportunity to do that.
Thank you. You're welcome.
Sure.
Let me see if I could restate the question. So the one region, they couldn't spend $2 million, but Commissioner said that the $56 million for next year would still be intact. I think what the concern is that that $56 million would become $54 million because they didn't spend the $2 million. Could that happen?
Probably not. I mean, what we're talking about, just to, again, reiterate, is the $56 million might be less because we decide to waiverize certain services.
Okay, you're not counting that.
But if $2 million wasn't spent, it's not as though the base would drop back to 54
Right.
in the following year. It's still funding that's available to be put out to fund services.
But we're not being allowed to RFP anymore. We have money that's sitting there that we can't spend.
Microphone.
Sorry, we're not being allowed to RFP anymore. We've had like $280,000 in our region. We RFP'd it. We still have money left over, and we're not being allowed to do anything with it. And it's taken us almost 2.5 years just to get to that point.
So I don't think that it's folks are not being allowed. So there's, in my
That's
mind
what
at
we're
least,
being told.
I think, so that direction probably came from me, so let me just explain what we were intending to do. Because we have this survey that's being issued, and we're really trying to understand where and what the specific program types are that people are being supported in, and I think folks certainly heard the commissioner's comments about crisis and behavior sports and service coordination. We need to better understand, you know, when you have a provider who's sort of giving back funds for whatever reason, we need to first understand, you know, the regional need, the services that are being supported, and if those services that are being provided are in any of these categories that we're sort of thinking about waiverizing or repurposing to support other programs, we're not going to issue an RFP knowing that we still have this survey pending and there might be some other use for those dollars. So I don't know the specific services that were previously being provided under that contract, but I think in terms of my comments to Margaret, we need to go back and look specifically at the services, understand regional need, and if there are recommendations put forward by the council, we need to understand that as well. So are you from Region 2?
Region 3.
3.
And
Okay.
just know that it's taken 2.5 years just to get to that final RFP. So what I'm hearing is could take another X amount of years. I mean, we need to figure out how to speed up the process because the money's been sitting there.
So maybe we can talk
We-
offline, because I don't
absolutely.
understand what you mean by the final RFP, but I don't want to take up
Sure,
this
not a
time to
problem.
talk about that. But thank you.
I'm from Region 3 also, and I have the same concern that Maria has. You know, we had an agency that relinquished their contract because they couldn't do it. And we have not been able to use that money for other things where there's a long wait list.
Is the entire amount from one agency, or was it multiple agencies that?
Ours was multiple, and it was over the course of a year of gathering. It kept growing. It went from 60 some odd thousand to 80 some odd thousand to 200 some odd thousand.
And part of that might be that if you have, and I know it may not seem small, but if you have $60-some thousand, it's not really cost effective to issue an RFP just for that amount of money. So that probably resulted in part of the delay. But you're right, as it grows, then it's,
Right.
you know.
It becomes more difficult.
Yep.
But it doesn't grow. I mean, it zeroes out at the end of the year, and you start another year.
Well, we
You
should talk offline then.
You can't carry over from one year to another.
Well, then it must be 1 year. I can't speak to the
Yeah.
final details.
Okay.
We can
Right,
talk
I
later.
think that's what we need to look into and assess.
If it's not cost effective to RFP a small amount of money, why can't we, at our discretion, knowing what our needs are, use the money at another place?
We have state finance law that we have to adhere to. These are state dollars, and state law governs how we contract with and provide payments to organizations. There's an inability to simply decide I'm going to spend $60,000 with organization X without a competitive procurement. So these have to be competitively procured.
Does that make sense? You have a quizzical look on your face.
Does make sense.
It does make sense. That's what I was
Okay, all right. Thanks.
My quizzical look is aimed at the state.
Yeah, I know, but, you know, we're all the state, but we have rules too, so.
Gail presented the information about how important it was that she got the services because of family support services. And you're saying that you want to maintain the ability to provide services for people even if they don't have the opportunity to be in the waiver program just yet. Where is family support going to be in all of that? What part will we play in that?
In our crisis response system specifically?
Sure. Right.
I don't know. I mean, if we're looking at trying to waiverize, if you will, I know it's a really horrible term, but, you know, to maximize federal financial participation, we would take funds and we would expand the capacity of OPWDD's funded program. And obviously it doesn't work that well.
Right. Because, I mean, and I don't mean to downplay the state, but when the state gets involved, it's such a big hassle. And so
I
my
understand that.
concern is, how will family support be able to support the state?
So
help the
I would
people?
frame it differently. I would say, how do we collectively, OPWDD, family support councils, address crisis needs around behavioral supports? That's, to me, the goal. Not like how I do it or you do it, but collectively, how do we respond to that need for service? And we have one system that operates under the waiver, and you have a different system that operates under grants through contractors. And we do some things really well, and you do some things really well. I mean, our being able to maximize federal financial participation through the waiver is really valuable because it turns $1 into $2, turns $4 billion of state appropriation into $8 billion of service. That's pretty cool. On the other hand, what you do with family support, as you know, Gail's described it, is really important. You provide a higher quality, sounds like, service than we can provide currently. So I'm going to have to make trade-offs. I've said this at the very beginning around what we can invest in as we go through this next budget cycle. I want to find ways to not cut services, to at least maintain capacity. Can I put funds through the waiver, obtain the federal match, and preserve program quality? Can I learn from what you're telling me and make our IBS program a better program? Am I still willing to use state dollar only to fund people who are falling through the cracks because they don't have Medicaid, OPWDD, or waiver eligibility? You know, what can I do to maximize the value of the dollar that we have available to spend? So that's what I want to look at. That's what I'd like to try to accomplish. Make our program as good as it can be based on what you have learned and what you're going to teach us. I don't know, to go back to your core question, what the role of the Family Support Council right now is in terms of our crisis system, and I don't know what it's going to be, you know, in the future. But I think it's something that we all have an interest in.
In the survey that you did, we never saw the final version. So were you asking how many people, for example, and how many units are you supposed to serve, and also how many did you serve? To know which programs might be underutilized.
Yeah, we asked for what the contract stipulated in terms of, total, you know, units provided. You know, I saw some that had like information referral, you know, units, and what was actually delivered. Yes, we are trying to get that sense.
Okay, because that should help you in your decisions going forward.
Yeah, we'll share all that once, you know, we get the categorizations complete with the RO, and, you know, everything else kind of falls into place, so we can share the details, and, you know, we can work with you guys to show, you know, if there are certain programs they have specific questions on, like housing, you know, advocacy. We talked about, you know, behavioral interventions. Those are things that we can make sure we outline and look at as we map to the higher level. So.
I'm thinking about service coordination, because I know I haven't been on visits in a couple of years, but for the service coordination programs, what they were doing was getting people into the waiver, turning them over, and having to recruit new people, and they were struggling to meet their numbers, some of them. So you may find something there.
Yeah, because I think that, you know, with the implementation of the CCOs, they perform the same function in terms of assisting individuals with that pre-eligibility work.
Yeah.
So there goes the duplication. So I can see why those vendors would have a difficult time meeting their numbers, because as folks contact the front door and are engaged with CCOs, they are performing
revolving door.
the same function.
Yeah. On the other hand, there are families who will not have Medicaid eligibility and will need the service coordination that's state funded. So there has to be a kind of balance.
Understood.
Also, wanted to just say, the data that was collected on the survey was from 2018 contracts. Is that accurate?
Yep.
So 2018 was quite the year. And I believe, and I hope I'm not speaking out of turn, I can speak from our region standpoint anyway, that many of the FSS programs, not just service access, but many of them were impacted and underutilized as a result of transition, care managers learning new systems. I happen to work for a provider, and our provider has always met milestones, and like one of my is spend it all, make sure the families get it if they need it. And we typically have had historical success with that. In 2018, we definitely saw a significant change, and I do believe it was a result of many environmental factors, including CCO transition. I myself wasn't able to get some referrals because I had a lot of, we've had turnover, new care managers. So I'm hoping that that is being taken into consideration too, because the year that we picked to analyze was a very difficult year that had a very strong hit on FSS program utilization.
So I believe in the survey, we also asked the vendors or the providers to provide some commentary, some notes. So to the extent that they have noted that the implementation of CCOs or some other factor has impacted the units or the numbers served, then we'll certainly take a look at that.
Excuse me, maybe to tie in with that, I got an email here from someone. It's in Region 1, but the behavior management programs were listed as training and not crisis. So I maybe taking in consideration those notes and kind of, figure out, are they really talking about the program's really crisis or are they training?
So, Anne, I'm not sure what you mean by you got a note from someone in
I got an email
Region?
from someone in Region 1.
We're getting
okay, so
feedback.
So again, we are doing a deeper dive into the specific program types and categories. That's ongoing work that's occurring, so we'll certainly be able to parse that out and report back specifically on the program types and the cost for each of those program types. So this is sort of a preliminary sort of categorization of what was included in the surveys, but once we do a deeper dive, we'll be able to come back and report out.
Okay, thank you.
And just to add on to that, just because the program reported it under a certain type of category, the regional offices did take a look, and using the categories that central office wanted us to categorize them, some of that may have been moved.
Okay, thanks.
Okay. Any more questions? If there are none, we can go to having public comment from those people who've signed up to do so. Josie's moving.
I'm calling remotely.
Yes, we can hear you.
Hi. Hello?
Yep, we can hear you on the phone.
Oh, hi. Okay, great. Thank you. Thank you so much. This is Jody Molmeister calling from the Hudson Valley region. I just wanted to make a comment regarding the conversation about intensive behavioral services and the START program, and the focus on crisis management in order to keep people in their homes. One of the things that we've been bringing up very frequently is that many times the reason people
So Jody, this is Abiba. We'll certainly have the regional office engage with you because we want to get, with permission, of course, a list of those families and names so that we can follow up. But I know specifically with the workshops, folks either transition the programs into an integrated business model, or there were alternatives provided to those folks, whether it be site-based day programming or some other specific day service of interest. So we definitely would like to follow up with you to more specifically understand the needs of the individuals. The regional office certainly has the ability to review capacity, and where there are specific needs, we have issued RFS for new development of programs, so we want to understand what the specific issues are.
All right, thank you. At this point, we'll go on to the public comment. I think Chris Greif is our only presenter today.
Yeah, he's the only one.
First of all, I'd like to put the mic a little closer so everyone can hear me in TV land. Good afternoon. I am Christopher D. Greif. No, I'm not a self-advocate. I'm an advocate for people with disability. And I will say that every time for the record, advocate for disability. One thing that I heard a lot of things, but there's one thing that I saw in the category I'm glad to see is outreaching. The one thing that a lot of our councils do is they do outreaching. They do little mini. I know Brooklyn, we do the mini resource fair, which I am the chair of that committee, as well as we do our super one. And together we work together to make sure agencies do fill up their slots. But I do remember Jackie in the first meeting did mention the rules and regulation, what is our role for the advisory council. And I do want to thank Josie because that information is very excellent as well. Thank you for sending us to us in the past. The main thing is as I said before, and I will state this again, we're now ending to 2019 and we're heading into the 2020. It's glad to know we have information, but again, there are, as I heard from Hudson Valley, and I see this in Hudson Valley, I see this everywhere. We need to work on outreaching more strongly, not just into the agencies, but outside the agencies, to work together to get individuals to see there are other ways of working together. If Special Olympics can do it, so can we all do together. That is one thing that we got to keep advocating. If Long Island Railroad or MTA can do work together, now, because we have things called the fast forward, we need to work together as strong, not just strong advocates, doesn't matter which advocate position you have. And I've been saying this since day one. And the second is, maybe I have a disability, but you know what? At least I got the help. But I want to help my fellow individuals who has disabilities. I want to make sure that in 2020, they're not outside in that cold weather. So, Commissioner, and all staff from OPWDD, we need to make sure that our individuals are not outside in a train station. We need to make sure they're not outside of a building, cold, freezing while they're out there. They might have a disability or a mental health issue or any kind of disability. We need to work with the Department of Health and Mental Hygiene and the police forces together to get the safety. And I've been saying this from the MTA end. I said this to every elected official. But as I said from my New Year resolution, we need to work together as strong as advocates. I have here, and I always do this every year, my outreaches. I have my mini one, and I have my super one to make sure that agencies, parents, staff are getting the information out there. So I am asking, let us work together, and let us have a happy, healthy New Year. Thank you.
Thank you, Mr. Greif.
Oh, thank Thank you again, Commissioner, for saying our last name right. You don't know how many people butcher our last name. Thank you.
Just got lucky, that's all. Thank you. Okay. I think that concludes today's meeting. Thank you for coming here and appreciate your time and expertise and look forward to speaking with you again.
Yes.